Hey everyone, welcome to This Explainer. I am so incredibly excited to have you here today because we're going to break down the complex, but honestly, absolutely fascinating mechanics of Parkinson's disease. We're going to literally map out exactly what goes on inside the brain and body. By the end of this explainer, you aren't just going to be memorizing facts. You're going to fundamentally understand the mechanical logic behind these symptoms and the treatments. All right, here's our roadmap for today. First, what is Parkinson's? Then, the mechanism and cause. Third, the four main symptoms. Next up, the secret of levodopa. And finally, a crucial warning about CRNS. Let's get right into it. So, what actually happens when your brain forgets how to release the brakes on your body? I really want you to keep this image of a brake pedal in your mind for this whole explainer today. It's literally the master key to unlocking how Parkinson's disease works. Okay, section 1. What is Parkinson's? Let's define the disease. Basically, Parkinson's disease is a condition where the production of one very specific substance in the brain drops way, way down. That substance? Dopamine. Because of this massive drop, the person loses their ability to make smooth physical movements. So the main things you'll see are motor-related symptoms. It's really a fundamental breakdown in the body's entire movement control system. Moving right along to section 2, mechanism and cause. Let's look at how normal movement actually works. You know, when you decide to take a step, your brain doesn't just smash a giant go button. It's actually this incredibly delicate chain of command. First, the cerebral cortex issues the initial command, basically saying, hey, let's walk. Then, that signal travels down to a part of the brain called the striatum. From there, the striatum passes the message to another area called the globus pallidus internus, or GPI for short. But here's the catch. It tells the GPI to apply moderate brakes while walking. Now, what's totally fascinating here is the relationship between these two brain areas. See, the globus pallidus internus has a very distinct personality. Its default state is to just slam on the brakes and stop all movement. It absolutely loves braking. If left to its own devices, you literally wouldn't be able to move at all. But the striatum, it acts like the manager. It steps in and forces the GPI to use some moderation. It's like, hey, we're walking here. Just apply a tiny bit of braking so we're smooth and controlled, not jerky. So how exactly does the striatum get the energy to do this big managing job? Well, according to the source material, there's a really fun analogy we can use. Just like the famous anime character Doraemon goes absolutely crazy for his dorayaki pancakes, the striatum's absolute favorite food is dopamine. This dopamine gets produced in an area of the midbrain called the substantia nigra. When the striatum gets its favorite meal, it works perfectly, keeping those brakes beautifully regulated. Right, so here is the crucial turning point. In Parkinson's disease, that dopamine factory, the substantia nigra, starts to degenerate. Dopamine production just crashes. And without its favorite food, the striatum essentially turns into a lazy teenager. It just completely quits its job and stops managing. And remember what happens when the manager leaves? The globus pallidus internus goes rogue, doing whatever it wants. And what it wants is to indiscriminately slam the brakes on all body movements. All right, section 3, the four main symptoms. Let's look at the signs of Parkinson's. Now we can see how this all builds our understanding of the four cardinal motor symptoms of Parkinson's. We've got resting tremor, bradykinesia or akinesia, postural instability, and rigidity. I'm going to connect every single one of these right back to our stuck brakes analogy. First up, resting tremor. Because the basal ganglia is failing, the person can't maintain a steady, unmoving posture, so they develop a tremor. Clinically, this is really specific. It's typically asymmetrical, meaning it usually starts on just one side of the body, like one hand or foot. Plus, it often looks like a rhythmic tapping motion, kind of like tapping out a beat. And the key takeaway here? It happens specifically when the patient is at rest. Next, we have bradykinesia, which literally means slow movement, or akinesia, which means no movement. When the brakes are slammed on, movement just grinds to a halt. This brilliantly illustrates how it affects the face, causing what we call the mask-like face. Because that extreme braking prevents facial muscles from moving naturally, the patient develops this expressionless, unblinking stare. They look almost like a static festival mask. Oh, and their handwriting can also become extremely tiny. That's called micrographia, because their movements are just so constricted. The third one is rigidity. Now, this isn't just your everyday stiffness after a workout. Because the movement brakes are being applied so intensely, muscle tension is dialed all the way up to maximum. If you were to take a patient's arm and passively bend it, it wouldn't be a smooth, normal resistance. It's actually called cogwheel rigidity because the limb yields in these stiff, clicking, gear-like increments. You can literally feel the biological brakes catching and releasing. There's a fascinating clinical test for this called Meyerson's sign. Try this on yourself right now. Just gently tap yourself repeatedly right between the eyebrows. At first, you'll blink, but after a few taps, your healthy brain realizes there's no danger, it habituates, and you just stop blinking. But a patient with Parkinson's, because they've lost that smooth movement control, they'll just keep blinking with every single tap, totally unable to habituate. It's a really striking visual representation of the disease. Moving on to Section 4, the secret of levodopa, treating the root cause. Now, you might be thinking, well, if they need dopamine, just give them a dopamine pill. And yeah, we do have standard dopamine in hospitals, but it's used as a vasopressor to raise blood pressure. If you try giving it for Parkinson's, it completely fails. Why? Well, because the brain is protected by a super strict security system called the blood-brain barrier. Standard dopamine simply cannot get past those security bouncers. But levodopa? It's a precursor. Think of it as baby dopamine. Because it's still immature, the blood-brain barrier just lets it sneak right through the gates. Let's trace this incredibly clever pharmacological journey. Step 1, the levodopa is ingested. But here's the catch. There's an enzyme in the blood called DDC that really wants to mature levodopa into standard dopamine before it even reaches the brain. If that happens, it gets blocked. So, step 2, we pair it with a bodyguard drug called carbidopa. Carbidopa's entire job is to block that DDC enzyme. This allows step 3 to happen. Our baby levodopa safely sneaks straight across the blood-brain barrier. And finally, step 4. Once it's safely inside the brain, it transforms into the usable dopamine the striatum has been desperately craving. It is just such an elegant solution. And finally, Section 5. A critical warning about Serenase. A dangerous mix. Okay, we need to discuss a really vital medication here, Seranax, which is also known generically as haloperidol. In a hospital ward, this is a heavily used drug. Usually, when a patient becomes highly agitated, restless, or delirious, Seranax is given to help calm them down. It does this by competitively binding to and blocking dopamine receptors in the brain, so it effectively lowers dopamine activity. But please, pay close attention to this massive warning. Think back to everything we've just learned today. Parkinson's disease is caused by a dangerous lack of dopamine, right? Which causes the movement brakes to slam on hard. So, if you give a dopamine-blocking drug like Serenase to a Parkinson's patient, you are wiping out what tiny amount of dopamine they actually have left. The result? Completely disastrous. You will severely, dramatically amplify their braking symptoms, literally locking their body up. And that is exactly why it is an absolute contraindication. So, that brings us to our final, thought-provoking question for today. If a patient with Parkinson's disease becomes highly agitated or delirious on the ward, why must we immediately look for alternatives to standard dopamine-blocking sedatives? Well, now you know the answer. You understand the profound mechanics of the striatum, the rigid braking of the GPI, and that incredibly delicate balance of dopamine. You don't just know what to do anymore, you know exactly why you're doing it. And honestly, that is the true power of understanding the mechanics of movement. Thanks so much for exploring this with me today, and keep asking those great questions.